I am Enrique Pfeiffer, Chief Medical Officer of Sonomed Escalon, and today we will be conducting a webinar about the optimal ICL results using the Sonomed UBM AI and the impressive Guru AI nomogram. I am also joined by Dr. Roger Zaldivar, President of Zaldivar Eye Institute, and Adrian Santacroce, Clinical Application Specialist with Sonomed Escalon. We're very happy to have more than 200 subscribed people to the event and hope that all of you will learn something new after attending today. Should you have any questions during the presentation, feel free to submit them using the Q&A icon in Zoom. We will address them at the end of the session. Let's get started. Sonomed UBM AI, in conjunction with Guru, is a breakthrough in ICL sizing. The Guru nomogram uses the very best set of images acquired by the UBM, which provides the dimensions of the posterior chamber of the eye. The information, together with the anterior segment dimensions that you can see schematically on the right image below, and some other variables, permits the Guru to provide a very accurate prediction of the behavior of the ICL once implanted. The comparison with an iceberg brings the idea of the relevance of the dimensions of the posterior chamber. This part of the anterior segment can be only seen by UVM images, which is the area where the ICL is going to be implanted. The whole procedure allows the surgeons to move away from guessing to a full control of all the variables involved in ICL selection. The Guru is an impressive nomogram using a deep learning algorithm to process well-aligned images to provide an optimal result. Further, post-op feedback is fed into the algorithm so that it continuously improves over time. One of the major advantages is to detect and consider the inconsistent anatomies, which are the main reasons of outliers, a deterrent for surgeons to consider ICLs as a first option when offering refractive procedures. As shown in the image, the Guru suggests the best fit ICL for the eye. What is going to be the central and peripheral bolt? What is going to be the remaining anterior chamber angle after the implantation? And what are the chances for this ICL to rotate, which is particularly relevant when a toric ICL is implanted? The Sonomed UBM AI offers a sophisticated image acquisition method. It helps to acquire aligned image with the eye tracking and align assistant. Select good images in second plane, stop the unit when the enough number of good images are captured, and stop the scan automatically. After this process, or simultaneously in the PBMX HD, it also filters all the good images with the Guru DLL. This is a double check to secure that all the images sent to the Guru server are good to be processed for calculation. It is worth to mention that most of the process is completely automated, avoiding the subjectivity of the operator. No more user image selection, user caliper placement, and manual averaging distances. This is very relevant because it does not require an expert ultrasonographer to conduct the exams. Any staff with a little experience can adopt the technology very easily after a short training session. During the last 3 years, we have installed devices all over the world, works with all demographics. Now, Adrian Santacroce will provide the details on how to use our UBM AI system. Go ahead, Adrian.
Thanks, Enrique. So my name is Adrian. I'm the Clinical Application Specialist with Sonomed Escalon. I'm going to talk about our UBM AI tools and how it works with ICLguru. In order to do calculations for ICLguru, you need well-aligned UBMs. But who performs the UBMs? In the past, only experienced examiners could perform a UBM. Most practices do not employ ultrasound specialists, which makes UBM inaccessible. But now with our UBM AI tools, people with no experience can learn and their scans are standardized. Usually when I train clinicians, it's technicians who've never done UBMs before, and I'll come for a morning or an afternoon, and by the end, they're able to do UBMs all on their own. But it is very important to have well-aligned scans. If you want to have accurate calculations, you want to give good data to ICLguru. So there are 3 landmarks to a well-aligned scan. 1, it has to be horizontally balanced at the 12mm focal point and centered on the screen. 2, there's a vertical parallax joining all the apex of the curves being crossed. And 3, you want the largest possible posterior lens capsule in view. That means that you're very centered. And our 35 megahertz probe is ideal for this. We also offer a 50 megahertz probe, but our 35 is really ideal for this application. ICLguru only accepts well-aligned UBMs. They have their own criteria for what they deem acceptable to base a calculation on. And their DLL is built into our system. So that means anything that is accepted is kept, and anything that is not accepted gets discarded. Now here's an example of 2 UBMs. One was accepted by ICLguru and one was not. Without our UBM AI filtering tools, it's kind of difficult to find the difference between the 2. They both look like good scans to me. If I was the examiner, I'd feel pretty good about both of them. But when we apply the filters, we see one is green and one is red. The one on the left has a high alignment score and was accepted by ICLguru. The one on the right has a low alignment score and was not accepted. And you can see by that arrow at the top, that means that that scan just needed to be a little bit more to the right. So it can be pretty particular. However, our UBM AI tools help the examiner to achieve only the well-aligned scans, and it's standardized. So no matter who's doing the scanning, it's always going to be well-aligned. And those UBM AI tools are eye tracking, align assist, and auto capture. I'll go into more detail now. So the UBM AI tool that is eye tracking is real-time UBM image analysis on each scan frame for excellent alignment and positioning feedback. In real time, you are provided with corneal thickness, anterior chamber depth, lens thickness, angle to angle, and sulcus to sulcus. And those measurements only pop up when there's proper alignment. Next, there's the Align Assist. This is an on-screen display of scan alignment quality with indication of vertical positioning, tilt, and overall alignment. And this provides immediate and intuitive feedback. So as you're examining and you're trying to get your alignment, if there's an arrow going up, you know that the scan needs to move up. If it's going down, you need to move it down. So this helps you while you're scanning. You're not guessing what you need to do. And last, auto capture. Our system only selects the best and acceptably aligned scan frames, and it works by you press the foot pedal once to begin the scanning. Once the system has captured 20 well-aligned scans, the scanning will stop. So that means that the user is not having to focus on starting and stopping the scan, scrolling through, using their own judgment to what they think is a good scan. The filters are automatically built in, so the user can just focus on alignment, and that's it. This is what it looks like in real time. You press the foot pedal once, it begins the scanning. You focus on getting your alignment, and when it stops, just like that, there it is. Once it stops, that means it's captured 20 well-aligned frames. So we'll show that again. So foot pedal gets pressed, it captures 20 scans, it stops, you start it again, and in just seconds, you get 20 more. So after you do that, you press a button, just says Zaldivar ICLguru, and it transfers all of this data to ICLguru. So that includes the patient demographics, a composite video clip of your 50 best captured frames, the best 3 aligned frames with eye tracking overlay and without, and an XML file with all of the biometric data and averages. So after you do that, you can go straight to ICLguru. And all you have to do is type in the ICL power that you plan to implant. You upload the UBM from the cloud. And after you do that, the anterior chamber measurements are automatically populated. So there's no need for manual caliper measurements or manual entry. It just automatically pops up. And then that brings you to the calculation page. So this is the right eye. And then you click OS for the left eye. I'm not going to go into detail about this. Next, we're going to have Dr. Roger Zaldivar.
Thank you very much for organizing this, Enrique and Adrienne, and all the good friends from Sonomed. I'm going to give first a comprehensive sizing volume, because sizing is not something that you can talk 5 minutes and that's it. It's very, very complex. We have spent years trying to understand this, but as in a nutshell, I'm going to give you some new information here. I see some great friends. My great friend from Ireland, Brendan, is there. That is very late in Ireland. Debbie Mandagi. I see lots of users, and it's really cool to have you here, guys. So everyone knows the ICL has been an amazing solution for everyone willing to correct their vision. There's impossible to deny this. The material is quite unique, 30 plus years of experience, Collamer. Patients are happy, extremely happy after procedure, and you measure that the quality of vision is amazing. Where is the hurdle in this story? Absolutely in the lens selection, and everyone doing this is very difficult. That tells you something different about this, because it's really something that has improved a lot with EVO ICL, with the central circulation, but it's not something that is solved. It's something that it's always limiting the universal adoption of this amazing technology. And here is what we are trying to accomplish, that is making this a truly universal procedure that everyone can perform with a very clean playbook. So if we go to the exchange rate, which is something very important in everyone doing vision correction procedure, is how many ICLs we need to take out, because we are compromising the eye, the human eye. We have a quite variety on the exchange rate, jumping from 0.3 on the FDA study, we can talk about that, to 2% on some specialists. It's around, mostly we can agree, and I will show you a couple of more experienced surgeons, that is around 1.5, 2%. That's the standard exchange rate, and it can go higher depending on other situations, for example, rotation. But number one cause is vault miscalculation. If we see the different studies in the last couple of years, we have, as I was saying, the FDA trial that was 0.3, but when you see the small print, there were quite a bunch of patients with more than 1,400 microns of vault. So, of course, you can leave the lens inside, but if the overvolt has some compromises for the eye, and it's not an ideal situation, not even for the patient nor for the doctor, and we can go on that. But basically, the most important, as I was saying, cause of exchange is improper vault. And if we go to this paper, that is real world data from very good experienced surgeons like Andrea Russo, Eric Mertens, Sheradaya, Giacomo Sabini, Carones, they are all amazing surgeons and really experienced vision surgeons. You have 22% of patients that were outside the 250, 750 range. Is this a problem? No, not at all. This is just a description. We'll see in detail more about this. But these are where things start getting interesting. They had 2% of toric rotation. It's important just to bear in mind. 2 out of 100 of the patient that they have done had rotation. 1.1 exchange. And when we see the results one day, we have this amount of patients over 1,200, which is quite interesting, because think about the 3 millimeter anterior chamber having 1.2, 1.4, 1.5. micron volt, 1,500, is quite an uncomfortable situation. Even if it's not causing anything and you have good IOP, you are not that comfortable. Unless you have a 4 mm plus, that's like a lot. But this is the real life. Look at the range of results. It's a very big range. And there is where we are trying to remove. When we started attacking this problem a couple of years ago, we were obsessed on reducing these extreme outliers, mainly the ones that are in the overvolt scenario. We know hypovolt is doing much better with central circulation. Still is a problem on toric ICLs, and we will talk a little bit about that. So none of the outliers is positive for the patient. It's true that the lower sizes today, lower volts, are not as aggressive as it used to be in the past in terms of cataract formation. 100%, nothing to do. We have a stable volt over time, as we have been mentioning over and over again. But in terms of stability, it's going to penalize you. So ideally, you want to be in an ideal situation. So the good news is that there is more and more UBM being used in the world. And you will see that this is not 100% because many users are using more than one methodology, mainly in Asia and in Europe. This is growing in an important rate. And there are quite a bunch today, formulas, and many of them work good too. So we are going to focus on what we are doing basically. So AI is changing our world. We know AI is here to disrupt absolutely everything we do, and Volt is not going to be an exception here. Very quickly, I've shared this plenty of time, but then I'm going to share more stuff on this. But we know there is a basic Achilles heel problem related to Y2Y. And Enrique mentioned about this, is we are expecting that with an outer measurement to have a linear pattern in the internal configuration, and this is not happening, guys. When we see Y2Y and we correlate to angle, is very low, 0.3. Y2Y to sulcus, 0.28. Y2Y to cilia to 0.29. Nothing to do what's happening with the outer measurements to the internal configuration, where most of the times the ICL is sitting. Let me show you a couple of more stuff here. Let me clean this. So when there are situations where we have quite an acceptable correlation among all the different parameters inside the eye, which results in acceptable Y2Y results, because most of the cases, the Y2Y can work pretty good. It's not that every Y2Y is going to lead to a problem. It's a very forgiving platform. The material is amazing. And in most of the cases, it can perform. The problem is that there are situations where internal configurations are much bigger than expected, much bigger than what is expected related to external configurations, and other times where it's much smaller. What are the problems around this? When you get a very small recipe, you get a very small structure inside the eye where you have to fit something that is expected to be bigger because you are measuring something outside the eye and you are misreading the real world. What's happening inside? You get something with a lot of compression. What happens with compression inside the eye? You get a forward movement, forward displacement. What leads a forward displacement? You get basically forces coming from the lens, pushing a lot of resistance and trying to fit wherever it can. So asymmetry of the placement is one of the results when you get a lot of forces from the back. And the other one is a more anterior position. Those are two direct results of extra compression inside the eye. The other important thing, as you know, of course, even having a symmetrical position, is angle closure, as you know, or a very thin angle. But this is real world stuff, and we see this, unfortunately, every single week, not from our clinic, thanks God, and thanks to Guru and Volt AI. It's basically UBM AI. But basically, it's because there are still many people in the world using other methodologies or basically white to white. But it's not only about having IOP okay. Some people are just saying me, look, I have this patient, but the IOP is great. It's in 12. Should I sleep good? Yeah, you can sleep good, but this lens is completely underperforming. From an iris rubbing point of view, in the long term, we're doing surgeries in 30-year-old, 25-year-old. They need to have this lens 30, 40 years in their eyes. Imagine the situation in terms of pigment dispersion, IOP complication that may arise in the future, iris trapped in the shoulder of the lens, mechanically trapped, because the more anterior the lens, the more compromise is on the natural flow of the iris over the lens. And you get a bigger pupil as a result and increased photic phenomena. So nothing is free in the world. Again, what we really want is a controlled volt inside the eye, control volt with stability. We know that today we are much better and more forgiving with the central circulation, and with low volt, you can stay there with very little compression. But you have to know that very little compression inside the eye means that the ICL might rotate to the vertical meridian. This happens between 1 to 3% of the cases. Again, Enrique shared this. I'm not going to speak a lot about this, but it's amazing, the analogy. What would make you feel more comfortable if you have this image and you have to infer everything happening under the water? It's your call. You have to tell me what is the shape of this under the water. Are you going to tell me that this shadow is going to guide you? You have no idea what can happen under this. But it's much more comfortable for a surgeon to understand what is the complete shape of everything, and with an algorithm, sophisticated algorithm that keeps improving and improving, give you a recommendation based on many thousands of cases of what is the suitability on different conditions. So this is basically what we are doing in a nutshell. We are not inferring the rest of the picture due to one external measurement, nor something that is closer to where the ICL fits, but basically we are measuring the places where we have more chances to fit because of this eye configuration. That's basically what we are doing. We published this a couple of years ago. There are different locations for the ICL. The good news, guys, this was pre-Guru. Today that we are fine-tuning exactly the compression and everything where we want to fit, and the chances where the ICL is going to go, we are seeing more and more repeatability on the place where the ICL is locating. So today we are truly getting repeatable results in terms of this, because we don't get that extra pressure from the back to the front, unless we have an outlier that it can happen, but not the crazy outliers that I have shown before. Again, the project is called ICLguru. We are based on AI to select best UBM images by the absolute help of Sonomed, where they are selecting the best images for us. We are cherry picking those images. We are predicting the location and estimating compression and deformation of the lens. And we are trying to predict the angle distortion, because this is going to be very important. Understanding the angle is one of the important criteria that we have to assess, because that's what's going to give us the chances or not to deliver a result in that patient, and even to move forward or not. So we select the best images that are sent by Sonomed. We run our algorithm, and we are going to provide you, as Enrique was sharing, with these new guidelines that is much better than what we used to do in the past. Here, I'm going to explain just a couple of things. We are giving you the central volt here, and the peripheral volt, and the residual angle. As you can see here, that you have residual angle. You will get the chances that we consider the safety zone to finish in an ideal scenario. I'm going to explain what is this ideal scenario that is illustrated in green. And we are getting in this blue squared option what we consider the best fit. Is it that the final call? Absolutely not. But most of the cases you will be selecting this blue. There might be some cases where we are taking a decision based on chances, but there are two options that are good, and you can, of course, decide by your experience. And there's something that we have included that is very important, that is here, that is the rotational stability. Why is this so important? Because you might have two that are 100% in green. In this case, it's not ideal, but let's say that this was completely in green. But if you have higher chances to finish with better stability inside the eye, we will always select the one that has more green with better stability. That's important for torics. The other important thing that we are saying, I'm sorry, a little bit late with the time, but I have 10 more minutes, a couple of cases, and I'm done, and we can discuss. The other important thing that we have done is try to guide you guys. Here is very important, the guidance. We have learned in these couple of years that what ICL users struggle the most is not understanding what they are facing, what are the risks, how to assess their patients, and we are trying to give you all those tools to make you feel comfortable and confident. So basically, we are giving you different colors in order to assess the complexity of each case. These are the variables that we are using. We use magenta whenever we have higher volt than 1000 microns, or an angle, residual angle, projected forecast residual angle of less than 15 degrees. We have blue when we already have some narrowing of the angle between 15 to 20 degrees, or a volt projected more than 850 to 1000. Ideal range from 150 to 850. It's important to highlight that this is always considering central or peripheral volt. This is important to highlight. An angle over 20 degrees, and this is the boundaries, and of course a very low volt, less than 50 micron from center or periphery. It's not a cataract. This doesn't mean a cataract, but of course we are starting to be very close to the crystalline and might lead in a couple of years to a cataract, and we want to avoid that. Doesn't mean cataract, but is more likelihood of cataract. One thing that you will learn is that the different eyes have different options. There are eyes that are very forgiving and they have many greens, and there are eyes that are not forgiving at all and you have no greens. You have red or yellows, or there are eyes you have 1, 2, and 3. Today, this is the old version. We are sharing in a different way all these cases. You have 3 greens, but you have one choice. So we are making it easier for you. You don't have to be picking. We are making that job for you. What is the difference between these 3 greens? Rotational stability. This is what's going to weigh in favor of one or the other one. In this case, we have 2 greens. Again, rotational stability. And you have cases where you don't have any square blue, 0, like this case. Why? You can see the UBM. You have a very narrow angle from the scratch, very narrow, that whatever we do there, we have some compromise, and we understand this. And that's the reason why we are not giving you any option. Can you do this case? Absolutely. And we did this case, and it was okay. We put a 12.6, and it finished being okay. Of course, with a compromise, slightly compromised angle, but the patient is doing good. But we know the risk, we know the chances in advance, and that's what we are saying. So if you have to read this and understand this, what we are saying here is that if we put a 12.6, our projection is 294, which would be ideal, and the residual angle would be this. But life is about chances and probabilities, and we have 50% of the cases to have a narrow angle, 50. Just a small chance to finish in low volt, but most of the chances here are a narrow angle. But it's still okay. So we played our cards, and that was the result. Just to give you some more information, Henry, you haven't seen this, so I told you it was going to be worthy because I have many more stuff. But for you to understand the numbers, in 57% of the cases, we have 100% green. This is not what we are getting as a result. After doing the measurement, we have a proposal of 100% green, only 57%. The average sizes in green is 1 per patient. So most of the patient on average will get a clean result. But there are some patients that there is no 100% green. Like here, 38% of the cases have green, an important part of that option, but they also already have or blue or yellow already in the same option. It's not a clean green. What I want to be clear here. This is a clean green. So this is a clean green, you see, from 100% of the cases. So I'm just giving you some ideas on the numbers. And these are the clean greens that we get from every size, 68, 64, 62, and 50. So we have an important percentage of cases where we have mixed probabilities on each. So having a clean is of course the majority, but it's not in 100% of the cases. For you to understand in terms of sizes in green per patient, when you have one size, you have 26%, two sizes, 25, three sizes, 7, and four sizes, 1.8. So it's really interesting. Well, here we have Brendan Cummings that was part of this study. This was old Guru, but in those days, we have 100% of the cases below 416 microns. The big majority were really good, no significant intercenter differences among the different sites, which was really, really important. And let me show you 2 or 3 cases and I'm done here. Henry, you told me 10 minutes. It's going to be a little bit more, but I think it's worthy unless you tell me stop it here. But I have a couple of cases that are new and we are fine?
That's fine. Go ahead.
Okay. So we get case 1. And this is old Guru. And then I'm going to show you new Guru. This is the typical case that we want to avoid. Look at this. 13 millimeter wide to wide, 12.4 millimeter angle to angle, big ACD, and 7 diopter myopia ICL. So huge wide to wide. With 13 millimeters, you have to fake the system, put 12.9, and it's going to tell you that you need to put 13.2 OCOS. OCOS is telling you. So that's the angle to angle, as you can see there. And that's the old Guru suggestion. We don't know probabilities here. We don't know chances of succeeding. We don't know rotational stability. It was very limited, but was a first approach and already did. And it really helped at the beginning. Now we are in a different level for sure, but it already helped. Look at this. So STAR recommended 13.7. We did a 12.6. Look at this. With a 12.6, we were around 500. The 13.2 was 538. My experience and my father's experience for sure, whenever we had in old Guru, a magenta like this, we were already understanding the principles of extreme compression and that something was happening. So if we had 3 options, we selected the one in the middle. So this is how someone with different experience, we might have better results doing the same algorithm than someone with no experience. So in this case, using a 12.6, we had these results, 765 with a 12.6. So 2 sizes less than what STAR was recommending, and we already get some interesting compression here. It was an outlier of 300 something, but imagine if we have done 13.2 or 13.7. This was the beginning of this big story. I just wanted to share with you what happened. This is the case, as you can see. You already have some compression there. So let me show you a couple of cases. This is a patient with 3 millimeter ACD, wide to wide 12.4, angle to angle 11.4, OCOS 13.2. As you can see here, the KS from Kimi-Shimizu formula is suggesting a 13.2. From this and Nakamura, 13.2. Guru is suggesting a 12.6. Why? It says, look, you don't need to go and push the boundaries. With a 12.6, we are protecting 400 microns with great stability. We don't need to go to a 13.2, where despite we can have a good result with 730, we already get some compromise, we might experience some compromise because we are already feeling some compression, and we might finish with a very high volt. There are chances to happen this. Whenever you start having this, the results get more chaotic. You lose control. Everything gets more noisy. So this is what we did. We selected the 12.6 and we put it horizontal. This comes from Revive, and we got 460. Exactly what we were projecting, 408, and that's exactly what we were projecting with a 23.3 degree angle. You remember what was the projection? I think it was 25. Look, 25.5, which is really good because we have a sense of what's really happening with the angle. Is it a 13.2, a complication in this case? I don't know. I honestly don't know. What I can tell you is that this angle is going to get smaller, for sure, narrower. You are definitely going to get a bigger volt, and you might finish slightly tight in a situation where there's no need. We are taking it to a next level. This is fine tuning. We are doing things with more control and science. Let's see another case. 3 point ACD, 3.2 or 3.19, angle to angle, 12 millimeters. Here we have different. We have a small white to white, 11.4, and the OCOS is suggesting 12.6. Kimishimizu is suggesting 12.6, and Nakamura, they are both suggesting 12.6. We are saying, look, 12.6 is amazing. We have 500 to 8, looks beautiful, but I have low stability. It's okay. We can do it and definitely do it because this is not a toric. But if it would be a toric like the patient that I'm going to show next, it wouldn't be ideal. What did we put? 13.2. We do 13.2 with horizontal positioning, and we got 545. Perfect. It's exactly what we were expecting. The 13.2, sorry, the 12.6 would have been probably good too. So no problem at all, but we are doing the things slightly better. Here another case, same OCOS 12.6, same case. Let me go directly to the rotation. So another problem that we face, and I think is very limiting, and more if we are delivering we need to deliver results in a very accurate way. Remember that patients are paying a lot of money, they're doing a big effort, they're waiting for the lens to be tailor-made in Switzerland or in US. They're waiting a couple of months sometimes, and we cannot just make them wear off their contacts, spend a couple of weeks without them just to prepare to a surgery. Let's do a surgery, and then the lens start rotating and they finish with double astigmatism. And if this happens in 3% of the cases or 2%, it's a lot. We are in a selective elective surgery. We have to deliver. We stopped using microkeraton for less than 1% of complications. We jumped to femto, less than 1%. We cannot afford to have these things where we need to get the patient inside the OR, start all over again, take it out, wait for the lens, for the eye to recover, do the surgery. That spends a lot of time, and the patient, the confidence is killed. So let me share a couple of cases here. We have this patient with -11 and one or two diopters of my astigmatism. We decided to go with a 12.6. In this case, by coincidence, the OCOS it was saying 13.2, which is amazing. There are many situations where it's completely opposite, but it's just understanding. Look at this. So the patient with the 12.6 that we selected in those days finished with good volt, no problem at all, 473, great volts. And after 1 month, the patient jumped to a 2.5 diopter of astigmatism. Of course, it's rotating. And the other eye, 275. We measure internal aberration versus external aberration with aberrometry. As I'm sharing here, we realized that they weren't 90 degrees from the other. Today, there are other methods. You can go to astigmatic mix, whatever. But basically, we re-rotated. And after re-rotating, after 1 month, one of the eyes, we were lucky enough that it stayed. The other eye keep rotating again, all over again. So we replace it with 13.2. So what would happen with ICLguru? And here are the important messages. ICLguru is telling us, look, you did 12.6. The vault was perfect, 100% green, but the rotational stability is mid. No good rotational stability. Today, Guru is telling us you have to do a 13.2. It's very easy. You don't have to do anything. You have to think. You have to follow this. It's telling us this is the ideal vault for this patient. So that's exactly what we did. We put the 13.2, and of course, it's doing great. Long story short, and just to finish the last two slides, before ICLguru Pro, we have 40, in our last 40 torics, we have 5% of these patients that were predicted to with low stability. Listen to this message so that you don't miss the message. In all the torics that we did in the last couple of months, and we have good images for Guru Pro, we have 5% of them that were low stability. 100% of the patients that we experience rotation have a prediction of low stability. 100%. This is big. It's a big message. So we could have avoided 100% of the cases that had rotation if we have listened or understood this before. So today we are barely doing a couple of patients with mid stability, because sometimes we cannot decide. We have only 4 sizes. With 4 sizes, you have to sometimes select the less bad. When in the future, if the company gets more options, we are going to even tailor-made this to avoid having these 6% of cases in mid stability and do 100% high stability. So long story short, this is our mean absolute error. We are getting really good. Most of the cases are under 100 microns of what we predict. We still can see some patients be over 400 microns. These are outliers for sure, and we are working on them. I think we're getting better and better, but the key here is that even a 400 micron from what we predict is not a terrible complication, and you can see the case is something that you understand. So we are always nailing inside the range of ideal for each patient, each eye configuration, getting better and better. So with this, I'm just going to show you what we are working on. We are adding some extra features to ICLguru, level of confidence. It's going to be another extra measurement where we are telling you 100% with super confidence, intermediate confidence. So adding even more reassurance of what we are selecting and we are being able. And the next thing that we already have, we are testing locally, is the vertical calculation. Sonomed has deployed this for us, and it's going to, as soon as we gave them the green lights, you already can do horizontal or vertical calculation and have a prediction if you want to start doing ICLs, toric ICLs in a vertical. And we are doing we are having very interesting results on this. I think it's another, and of course we are working on ideal sizes for future options, hopefully to give you the ideal size for each patient so that you have a sense of what would have been ideal for each case. With this, I'm going to finish. Sorry if I have been too much information here, but again, guys, the Aquaport has been amazing. ICL is a super option for vision correction, no doubt about it. And I do believe that what we are building together as a community reassures optimal results. And basically, we can have outliers, but we are really avoiding serious complication. I think that's what's all about it. We cannot afford to have serious complications, and we need to be more and more accurate in order to have more confidence, to be able to explain the patient that this is an amazing technique and be able to deliver and minimize risk and have extremely happy patients. So thank you for your attention.
We're going to try to make a final summary of the contents that we have been going through. To be considered the gold standard implies that the technology sets apart of any other option in the market. There are many unique exclusive features not available in other systems that secures a smooth and safe process. We offer 2 different devices with UBM AI plus Guru capabilities. ViewPad or ViewMax HD will be suitable to fit any clinic needs. Although we offer 35 and 50, we strongly recommend to use the 35 on any UBM AI-Guru applications for its excellent balance of high resolution and deeper and wider penetration, providing the best image of the whole anterior segment. We have developed together with the Guru Revive team all the unique and exclusive features offered from the very beginning of the project that started 3 years ago. Exclusive features of UBM AI includes eye tracking, pupil size measuring, auto selection of the best images, image scoring, auto capture with auto stop, Guru DLL filtering. The patient is automatically created in Guru Revive, auto completion of HD dimensions at the time of the calculation. The UBM AI plus ICLguru users also receive strong clinical support, including access to the Sonomed Escalon hub, a repository for training resources, case studies, and more. And on my last slide, I will summarize the topic discussed in this webinar and the advantages that UBM AI Guru will provide to any practice. We use AI to acquire and standardize images, mainly providing the dimensions of the posterior chamber of this anterior segment of the eye. The Guru nomogram, also using AI, precisely predicts the behavior of the ICL inside the eye before the surgery. This permits the surgeon to move away from guessing to full preoperative control of the possible outcomes. The surgeon will comfortably propose ICLs even in eyes where before it was very risky to implant an ICL. For example, in very shallow anterior chambers. It is a very easy to adopt in any practice, almost fully automatic process. More than 150 sites using it all over the world with more than 20,000 calculations today. This is a state-of-the-art technology at a very affordable price. Finally, do not hesitate to contact us for more information or questions you may have. We are now opening questions and answers. Dr. Patrick Versace from Australia says, what validation exists to show the predicted volt from Guru compared with the achieved volt? He says that the paper from 2025 shows the largest spread of volts around predicted.
Yeah, we are about to launch a new publication, hopefully very soon. But what we are getting basically is the last slide that I shared. It's a average 100 microns with that standard deviation. The one that I shared, it's 80 microns, but that's 56% of the cases below 100 microns. So that's mainly what we are getting. But the most important thing, again, is avoiding the extreme outliers. Is we are not getting more than 400. Yeah.
Worth to mention that in that spread, it was only one patient with a shift of 400 microns.
Yeah, the big majority is 97% is below 300, 87 below 200. So it's really getting very compressed. You are getting in a very narrow spectrum. And the more you follow the blue square, the more predictable you will be. Because if you measure with old Guru, you are selecting the patient. And we know today that the options that we provide are not do not have the confidence. They are completely different. We have higher confidence in some options than others. Some options are more chaotic. Now we are pre-selecting this in order to make it narrower and narrower. And we are going to even get better in the next couple of deploys.
How do I work UBM into my clinical workflow, Adrian? Does it take too much time? What is the way you introduce that on your practice?
Yeah, so I feel like most people, when they hear about UBM, they say, I don't want to put my patients through that. That's going to mess up the flow. But really, from beginning to end, meaning bringing the patient into the room, doing the exam, and getting the results, it takes about 10 minutes. In the beginning, when a technician is first starting out, it might take them a little bit longer, but once they get the hang of it, it's about 10 minutes. And for the patient, most of the time they aren't bothered by it. And Dr. Cummings actually had a really good point that seeing how the patient tolerates the UBM is actually a good indicator as to whether they'd be a good candidate for topical anesthesia for the actual procedure. So it's kind of like almost like a dry run. But it is very easy. Most of the time people say, oh, that wasn't so bad. You know, when they hear about what's going to be done, they're like, oh God. But it's really not as bad as you think. And it's very similar to doing an immersion A scan. So you have to have the patient not dilated at the time. Every clinic's a little bit different in terms of the workflow, you know, where you have the unit placed, whether that is available, whether your technicians are available. It kind of depends on your practice, but it really doesn't add that much time to a visit.
Roger, you explained the various Guru reports where there are the colors and the different lens options, but there is a question: what happens when the Guru is not recommending one given size? Why is that the case?
That's the case when you don't have a clean option where you have green and that you have a significant amount of red or magenta, which means that none of the sizes of star is good enough to fit that anatomy. So having said this, we still do many cases like this, but we know we have more chances to have an outlier. Hopefully in the future, perhaps we have more lenses, more sizes, and this won't be an issue, because with more sizes, we would be able to definitely fine-tune each specific anatomy. We are adjusting ourselves to what we have over the table. But my recommendation is, if you have a patient that doesn't have any option and it's related to magenta, I wouldn't proceed. If it's related to red and has good stability, I would proceed. We know that the tolerance of hypovol today is much better than before. And worst case scenario, you might have a low volt, but if it's a toric, you should always look at having high rotational stability. So the combination of red with high rotational stability is still doable if you have a significant amount in green.
One more last question. It says how ICLguru is better for doctors following sulcus to sulcus from the UBM so far. What is the difference between Guru and sulcus to sulcus?
Sulcus to sulcus doesn't make a lot of sense because it's an approximation of where most of the times the lens is sitting, that is in the ciliary process. So this is being even more and more accurate. And it's not one measurement. We are taking into account multiple measurements and even applying AI on things that we can control. And that's the beauty of AI, is getting much more information than just a single distance from one place to the other that is holding less than 5-6% of the cases. So it wouldn't make a lot of sense to do that. That's old. That's the old way we have been doing this. Now it's a new upgrade for sure.
All the sulcus to sulcus nomograms are also linear. Just depends on what, one dimension and linear. The Guru is not that case.
One of the big differences, and I don't want to get so much in depth on this, is that the formulas most of the time used in OCT, for example, and even they are 100% linear. They just get a playbook where they add a certain amount of increase. They are fixed steps. One size more, fixed step. One size more, fixed step. You will see, if you have been using Guru, that none of the steps that we propose are fixed. It depends on the different anatomy. So I think that's what's making a huge difference, and definitely what's going to be getting better and better for sure.
And we also have another question, says, what is your experience in finding iris cysts while doing UBM ICLguru, and would you recommend going for an ICL surgery despite seeing cysts?
So cysts, as you said, are more often than what you would think they are. There are several papers reassuring that you have 20%, and in some cases even more of the cases you will find some kind of cyst at the 180 degree angle. And the reality is that we have been doing this for many, many years with cysts without knowing. So what we are finding now is that small cysts, those that do not distort the anatomy of the chamber, of the internal structures, and do not cause a serious asymmetry, are not causing significant differences in the prediction results. However, if you do find a big cyst, those cysts that you see like a ball, that is completely making the eye asymmetric internally, you would expect some outliers and some asymmetrical positioning that might lead to a compromise in the angle over that side of the eye. So I don't recommend doing big cysts unless you find it comfortable that they are small. But just look for another axis. Go through a vertical positioning, and perhaps you have to be careful with the calculation, because we know that vertical, you might have slightly lower vault than predicted, but you can do somehow in an oblique position that is almost the same like horizontal.
Then Patricia Sierra is asking if I'm comfortable placing a toric ICL if the stability prediction is high, but on the lower end or high, what is the minimal volt? So it's not about minimal volt. You might have very little volt and you have good stability of the eye. Remember that volt is because of a compression of different structures and of the lens rise. You might have a patient with very high lens rise, which leads to small volt, but you have a very good stable platform. So it's multifactorial. So remember that. So volt alone is not a driver of stability. That's why this gets more and more complex. One of the graphs at the end, I shared that. So we have a couple of patients that where 6% of our patients are mid stability and they haven't rotated. So I definitely not doing low stability. I'm not doing low stability because that's a guarantee or high chances of having rotation. If you can throw your coin, flip your coin. If you have mid, most of the time it's going to be good. But I'm be even happier if I have high. If you don't have any other chance, I would do mid. We have been doing it with good results too.
Should there be any? I'm sorry, I was going to say that there's the mid and there's the high and there's a low. In the high, sometimes that dot can be like towards the lower part of the high. Should they have any concern about that, or should they feel comfortable?
If it's high, even in the low part, it's good enough. If it's mid in the high part and you don't have any other option, I would still do it. Then I start having doubts if I do a toric or a bioptics or not. These are the things that we want feedback from you guys, from our users. To every rotation with Guru forecast, please contact us because we need to fine tune this. This is where we are fine tuning.
It's Devi Mandagi asking for, or telling him that when there is low cylinder, he preferred to go for an spherical lens if there is risk of rotation, and then try to do the LRI to neutralize the astigmatism, which is pretty logic and pretty.
That's a really good. That's a really good comment, Debbie. As usual, he has been doing an amazing job in Indonesia. Absolutely incredible. What we are doing in these cases is when we see that there is not such an amazing option for toric, we are just doing a bioptic or some limbal relaxing incision. So that's another option when we are not comfortable enough with the toric stability, and we just put a spherical that we know it works great, and we do a laser.
Roger, thank you very much. We know that you are in a very busy schedule this morning. Adrian, thank you very much. And for all the attendance, our really appreciation for spending the time with us at this webinar. Please do not hesitate to contact us if you think that there is anything we can help you. That has been a very nice and successful webinar. We hope that we're going to be repeating along the year. Thank you very much to all, and see you next time.